Hi, everyone. Thanks for joining me today. We're going to be talking about Basic Opioids 101. This can be really helpful if you're someone that's new to opioids or you actually just need to re-explore what you've learned in the past. So let's get started. This was a labor of love to put together. Many PharmDs, NPs, MDs, DOs, so many folks have helped out to make these slides the best they can be. I myself and Dr. Hansen, I'm one of the geriatrics and palliative care doctors who helped create these slides together. So we're excited to bring this to you. Objectives today, we'll go back to basics. So we'll systematically assess pain as a symptom and then learn to categorize that type of pain, as well as introducing basic opioid pharmacology. We are true believers that if you understand the pharmacology, then you're more likely to understand how things work for your patients. We'll also briefly talk about common opioid side effects and things to look out for. Since this is just 101, we will just be reviewing the basics, so no fentanyl patches, methadone, or PCA in this talk today. Just briefly, we'd like to talk a little bit about some terms, mainly because we notice that things kind of get thrown around. Every person has their preference on what word they like to use. There is a difference, though. So you can see here the difference: opiates versus opioids. So opiates refer to the alkaloids found naturally in opium. So this is actually the classic morphine and codeine. We found them. We didn't have to really do anything to them, mess with them. They work just fine. But we also then, as a society, turned to developing opioids, which is refers to drugs with opium or morphine-like pharmacological action, essentially things that we created. So semi-synthetic opioids that were created from opiates, which includes hydromorphone, commonly known as Dilaudid, oxymorphone, oxycodone, and hydrocodone. And then fully synthetic opioids that were created are fentanyl and methadone. This is different than the word narcotic, which is a drug with any psychoactive compound. Honestly, this is just something this term is used in law and not necessarily ever used in practice of medicine. It's a drug that is totally prohibited by law or one that is used in violation of strict governmental regulation. So you can see now when it's all lined up with these three terms, how different they can actually be. For our sake of this talk, I'll typically be using the word opioids, just because we'll be talking about semi-synthetic opioids as well as those that are naturally occurring. So when we're even talking about, are we going to need opioids? Should I be thinking about it? It's really important to get that good pain history and assessment. This may just be a brief review for a lot of you. It's something I know we talk about with our medical students, but this is a nice, easy way to think about it. So when did the pain start? Is it something that's been going on for quite a bit of time? Did it happen all of a sudden in the last few hours? So getting that time course can be really helpful. What provocative or palliative features? I think those are very fancy words for saying what makes it better and what makes it worse. What has worked for you, or what is something? Is it worse when you're moving around? That's really helpful for us. Quality. So the words that you often hear are sharp, burning, aching. These are all helpful terms that the patient may be able to give you so that we can have a better sense of where this pain is coming from and what would work to treat it. Radiation and related symptoms, again, it's helpful to understand where things start and where they go. Is it something that classically, like right upper quadrant in your abdomen, it's radiating to the left, or it started to the left and now it's radiating out to all of your diffuse abdomen? And then any related symptoms. So what came with it? Does the pain come and then you become nauseous all of a sudden? Is it come because you are experiencing constipation? All of these things can be really helpful for our assessment. Temporal pattern, again, the time course can be really helpful. And then how does it affect you? Is it keeping you up at night? Is it affecting your ability to get out of bed every day? Or is it just something that you're like, I'm learning to live with, it's fine? This can be really helpful in how aggressive we need to be in our management. And then all of this history is really helpful in understanding that pathology. We like to think that pain just doesn't happen all of a sudden. Cancer just got worse all of a sudden, and the pain blasted through 10 out of 10 when it had been well controlled. Anytime we see things like that, like a new worsening of pain, we're worried about what's happening underneath. Yes, we can try and treat the symptoms of this pain, but also we can't forget that we need to find the reason why it's happening. Hopefully you're not foreign to these pain intensity scales. This has kind of become the universal scale, both because of the Joint Commission. Many hospitals have settled on this pain assessment tool. So you see here the classic 0 to 10 pain, 0 being no pain, and 10 being the worst pain possible. I find it's helpful to understand everyone can have a different version of 10. Sometimes someone's 10 is crawling out of the bed in agony, and other people are just hanging out having lunch and saying that they're 10 out of 10. That's really helpful for us to understand how it can be different per patient. If this person is unable to give you that numeric pain scale, maybe they're too young or unable to speak to you about that due to mental status or aphasia, understanding the faces scale can be helpful here. So that classic smiling face, no pain, and versus when you walk into the room and your gut tells you that that patient is just in crippling pain with the crying and just calling out in agony and thinking about the 10. I think what's hard about this is trying to discern the middle of the range. Did you hit your goal of 4? Does the patient look smiley, or are they okay and stable? So our first step in even talking about what medications we're going to use is we have to pull the picture all together. What was the history? What is the past medical history, the past surgical history? Did something new happen with a new chemotherapy regimen, or a new intervention that they had just gotten? Physical exam. I know it can become a lost art form, but our physical exam to better discern where the pain is starting, tenderness to palpation, radiating sciatica, things like this can be just so helpful in figuring out what is the cause of the pain. Labs, particularly renal function, liver function, because if you're going to be talking about opioids, you also have to understand how the organs are all working, and we'll talk about why that is. And lastly, imaging. It is very common that you find someone who is trained in geriatrics or palliative care, or maybe seeing some patient for pain, that you'll come in and say, hey, I am happy to help. And I actually wonder if we're missing something here and we need to get some more imaging, perhaps a CAT scan or a chest x-ray to better tell us what's going on inside. And while we're treating this pain, obviously our medical teams or us are trying to reverse the underlying cause if we can. So when we categorize pain further, we talked a little bit about kind of onset, quality. In order to help determine a good treatment algorithm, we're also talking about timeline. Is it acute? Has it been less than 3 months? Do we have kind of a clear injury or a disease such as cancer or some other chronic worsening of disease that could potentially be leading to this? Or is this something that's chronic? It's been with someone for maybe up to years and they may not know why it is. And even though maybe physiologically things should have been healed and the pain is still there, it could still be very much present. And I know that this is a whole other talk about talking about chronic pain and our connection between our brain and our nerves and how our body perceives it. But this can be really helpful for us because it will also guide what medications we want to choose or pain interventions. The next step in discerning categorizing the pain is the difference between nociceptive and neuropathic. What I always teach this is you really need to actually know because the treatment strategies can be quite different. Nociceptive is what we think of direct stimulation from a tissue injury. And that is actually because of the injury to the intact nociceptors. And that can be transmitted along all of the undamaged nerves. That's broken into somatic and visceral. Somatic, we think of as inflammation of the bones, the joints, the muscles. When the patient tells you, oh my gosh, it's just aching. It's And I'll say, oh, is it a pressure? Is it burning? And they'll tell you aching, it's burning, it's aching, it's stabbing, it's throbbing, but oftentimes it doesn't radiate. It's kind of localized to the area of damage where the inflammation is actually occurring. That's a little different than visceral, which is more of the inflammation of internal organs or smooth muscle. Oftentimes patients they very rarely can take their finger and point directly to where this pain is coming from. It can be diffuse, and that is often described as gnawing, cramping, colicky, and that pain may radiate. But keeping in mind that both somatic and visceral are nociceptive types of pain. That's different than neuropathic pain, which is actually the damage caused by injury of peripheral or central nerves. Patients will often describe this as numbness, burning, tingling, and it often radiates. Very rarely are you thinking about neuropathic pain when a patient gives you kind of a clear history of a pressure or ache. The reason why this matters is because opioids are actually not first line for neuropathic pain, but opioids work fast and they can offer some relief. So they do end up being oftentimes some initial treatment strategies for folks with neuropathic pain while we're figuring out other things, such as like a neuroblock or intervention with the pain team, or folks with a shorter prognosis, in which we know that our medications for neuropathic pain may take much longer to kick in. Again, a different conversation, but this is why it's so important when you're presenting, we have residents or fellows presenting to us, tell us the type that you think it is based on the words that the patient used in your history that you've collected. So for this talk, since we're talking about opioids, we're going to focus mainly on nociceptive pain because, again, opioids are second line for neuropathic pain. I always feel like this is a great slide to come back to because it helps me reframe what make sure I have a clear sense of what type and what level of pain the patient's going through. And that also can help me guide in what I'm even reaching for first. So for folks that are coming in with mild pain, and for our sake, we'll use just the numerical pain scale, 1 to 4, that's really not a place where we're going to be reaching for opioids. We do have some great non-opioid options, so things like acetaminophen, which is pretty well tolerated by most patients, and even folks with cirrhosis can still receive as long as it's under 2 grams in a 24-hour period. NSAIDs, which I am also Geri Pal trained, so I do know that we don't love NSAIDs in geriatrics, but for a younger person without renal function, it can be a really, really great option. And if we are using it for maybe an older, sicker patient, just a short course of NSAIDs, as long as we are being pretty cognizant of the side effects. Moderate pain is when we jump to 5 to 7 on the numerical pain scale. And that's when we would take those opioid adjuvant therapies like Tylenol and NSAIDs and probably add on an oral opioid. The starting doses, I think, is the biggest piece here that people is helpful to learn, mainly because you can always start low and add more. It's hard to take away. So morphine 7.5 milligrams PO, it comes in 15 milligram tabs, and we cut those in half. Same goes for oxycodone. We say about 2.5 to 5 is the starting dose. Again, for an older or sicker patient, may start with 2.5, and it can be pretty effective. And hydromorphone, or also known as Dilaudid, can be 2 milligram PO, or also actually cut in half for a 1 milligram. Now, if you're seeing someone and you've been called because they're in a pain crisis, maybe they have some active cancer and they are really struggling. I picture these patients in the emergency room where we're kind of coming down and seeing what we can do to help. They may give us a range of an 8 to 10. So we know that we need to find something that works and something that works fast. So in addition to those non-opioid adjuvants, we also are thinking about IV opioids again, and we'll talk briefly about the time course, but we want to make sure that we pull someone out of that severe pain crisis to the best of our ability and in a safe way. So morphine 2 milligrams IV or hydromorphone 0.2 milligrams IV. We joke because at the culture at our institution is that our residents love hydromorphone, I think because that decimal point makes it feel safer to them. But we do try to encourage morphine 2 milligrams in the appropriate patient, maybe because it's a little bit cheaper. Otherwise, you'll see the blue box here talking about interventional pain. These are things that are in the back of a palliative care doctor's mind. Or is a nerve block going to be beneficial here? Is this someone with a rib fracture on top of it? Or is there something that we've just maxed out all of our options? Spinal medications, spinal cord stimulator, or even surgery. This is all part of our toolkit in trying to manage this pain. So when you're even talking about choosing an opioid, we talked briefly about starting doses and how to do this safely, but keep in mind that there are reasons to choose one over the other. Technically, morphine, oxycodone, and hydromorphone are all primarily metabolized in the liver and renally excreted. What this means is that you have to be careful. A lot of sick patients may have concurrent kidney disease or a new acute kidney injury, a new liver injury, or liver metastases. And choosing things that are safer, particularly means maybe deviating away from morphine and also choosing lower starting doses and a larger spaced out frequency. Now, there's always someone that brings up tramadol, and we will say that it was initially when tramadol came out, where everyone was very excited about it. This is going to be safer. The effect is not as severe as opioids, maybe in older adults. We will say that in our practice here at Sinai, tramadol is metabolized to an unknown dose of morphine. And the classic board question is that it actually also blocks the reuptake of serotonin and norepinephrine. What this can mean is those folks that are on SSRIs, SNRIs, or perhaps another antibiotics that may interfere, it can actually increase your risk of serotonin syndrome. We have a joke in the geriatric department that we say tramadont, just because we don't love the potential side effects or the issues that this medication may cause. For this sake of this talk, we're not going to talk about tramadol, and it's not one that in our practice we readily reach for. There are some older practices of the use of meperidine or Demerol that has really fallen out of favor to the point I don't actually think our hospitals have it on formulary anymore, but it is something if it was in your practice perhaps in the past, we've really deviated away from that, especially in older adults, because the metabolites really can be incredibly deliriogenic, and even there's many documentations of seizures. So just like we briefly talked about, the pharmacokinetics of opioids and how they're excreted or metabolized is really important in making your selection of what type of opioid you're going to use. So you'll see here that morphine is honestly it's out for a lot of patients in terms of safety. Anyone with a creatinine clearance under 30 on dialysis, I will make an argument that anytime there's a new AKI also, it's just oftentimes not worth it because you're worried that is that AKI going to get worse overnight. Any kind of kidney disease, I move away from morphine and I look more towards an oxycodone or hydromorphone. The same goes for liver disease. So even folks with stable cirrhosis, we would really avoid morphine if we can. I know that our liver team at Mount Sinai really prefers that a hydromorphone or Dilaudid be the choice, the opioid of choice for their patients on the liver service. Oxycodone, interestingly enough, is still pretty heavily metabolized by both of these organs. However, we've come to kind of an agreement among our practice with palliative care that oxycodone is relatively safe in these diseases, as long as you choose a low dose and perhaps space out your frequency. Maybe instead of going Q4, you'll go Q6 to Q8, as long as you're making sure that these metabolites don't accumulate. You can see here, again, we're not going to talk about fentanyl and methadone, but they can be really helpful for folks with really advanced organ dysfunction. We find a lot that we have to reach for fentanyl patches in folks with cirrhosis, just because we don't have a lot of great long-acting options for them that can be well tolerated. You'll see here that the caution, the yellow part, or similar to what we were talking about with oxycodone, decreasing the dose by 25 to 50% or increasing the frequency just can be really helpful and really safe. You can always go up, and you are able to give maybe more frequent PRNs available to the patient. But in the act of being conservative and cautious, we do try to space those out at any kind of organ dysfunction. So there may be some instances where you're like, I just do not think this is working. We are going up on the morphine. They've been on it on the outpatient. We're coming in. It's just not giving me the same effect that it used to. And the patient is not comfortable. One of the reasons then to rotate is just that this opioid is no longer therapeutic. It's not working. So the fancy word is opioid rotation. You can also think of it as switching opioids. The other reason why you may also do that is the side effects. So someone that's having intractable nausea with the medication, perhaps pruritus, and there's a reason to try something new and see how the patient does. We've had many patients that have a ton of nausea on morphine, and then they switch to Dilaudid, and that actually subsides. One of the other more common reasons that I think on the inpatient hospital side to switch from perhaps morphine to something else is that new AKI, acute kidney injury. And so getting those labs and making sure that you're checking on it is really important. So enter the famous opioid equal analgesic table. Now, I will be the first to say that there in the palliative care community, there is a lot of controversy regarding how to do opioid conversions. A lot of theoretical risk, maybe not necessarily tried out. What I will say is that this opioid equal analgesic table has proven to be safe. Now, there may be instances where you feel like perhaps you're being over conservative based on these equal analgesic equivalents. That's okay. You can always go up. You can reassess how the patient is doing and always go up on your dosing. But you'll see here that each opioid is divided into what formulations are available. So for morphine, hydromorphone, and you will see that there's both an IV and PO version. But you'll also see that oxycodone and hydrocodone only come in PO form. Now, one of the things that we'll work through is this proportion at the bottom. Back to, I think it's 8th grade algebra when we are solving for X. We have this printed on a lot of pin cards for our fellows so that they can remember, but really nothing beats practice. So you'll see here the proportion that we use. And for instance, I'm trying to convert from morphine IV. We'll say patient is on 5 milligrams, and I'd like to get them over to oxycodone 20 milligrams PO. What you would do is take the current dose of morphine. So we said 5 milligrams and in the numerator, and then we move to the denominator. So what's really important here is to make sure that your numerator and denominator units are the same. So if you have morphine PO in the numerator, then your denominator should also be morphine PO. So in this case, I would have morphine 5 milligrams IV. And I would be then looking into my chart and say, oh, morphine IV 10 is the equivalent factor that I'll be using. So I would have 5 over 10. And that side on the left is only for morphine. Now on the right side will be whatever opioid I'm trying to convert to. I am trying to solve for X, which will be PO milligrams of oxycodone. In my denominator, oxycodone is easier. We only know that comes in PO, so I know that 20 is what that new opioid from the chart would be. And that would give me the proportion of 5 over 10 equals X over 20. Now, if you're like, I'm just not with you, that's okay. We have some practices in practice questions coming up. We do have to add something that's important here. So there is an idea that a body's receptors, particularly the mu opioid receptor, is used to seeing certain opioids. Maybe you've been on morphine for a long time. Your body is starting to get a little tolerant to it. The way that it's hitting the opioid receptor, you'll hear patients need to go up a little bit because they just got used to it. Now, if I tried to do an opioid rotation and I switched them to Dilaudid, all of a sudden that equivalent dose of Dilaudid works way too well and maybe has more side effects, a little bit over oversedation. And that, we believe, is due to something called incomplete cross tolerance. What we think is that the way that the morphine was hitting the receptor, maybe, although is hitting the same receptor, maybe is hitting it a little bit differently than the Dilaudid would. So the Dilaudid comes in, the body and receptor is not used to seeing it, and it really works without any tolerance and almost has too much of an effect. So in order to prevent the complications of this, mainly the oversedation, the side effects of seeing a new opioid when you were used to something else, we actually will reduce the dose. So in folks that maybe had really well-controlled pain, they've been on morphine, however, they came in with a new AKI and I need to reduce, and I need to rotate them to Dilaudid or hydromorphone, I will actually reduce the dose by 50%. For folks that maybe you could do a little bit better, maybe they're pretty well controlled, but maybe I would have gone up on their dose of their morphine had I not been switching it, you can just reduce the dose by 25%. And in those folks that you're like, whoa, we're not even close, this was not going to be the dose I was going to stick on, I may have had to double it, you don't need to reduce. This, I will say, if it feels very hand-wavy to you, it's because it is. This is all theoretical, but in practice, I think it helps all of us feel safer in what we're doing because we never know how each body is going to metabolize the medication, and that can be different from the patient we just saw. So in the spirit of opioid titration and dose finding, which I believe is the palliative care art form, we will essentially choose for severe nociceptive pain an IV opioid, just like we talked about. The mild to moderate to severe, these are patients that we need to jump in, fix it quickly, or at least take their pain down as quick as we can, and then we can reassess. How we do that safely is choosing the opioid and starting dose that makes the most sense. So again, to reemphasize again, if I haven't beat the dead horse, is the creatinine clearance is greater than 30. We, in our practice, reach for morphine first. Morphine 2 milligrams IV is a great starting dose. For folks perhaps with an AKI or a creatinine clearance less than 30, we reach for hydromorphone 0.2 milligrams IV, and that is our practice at our institution. So we're going to talk about the art of dose finding for just really the palliative care specialty, but many residents and fellows of all specialties should be comfortable with it. And that is choosing the opioid and then administering it, and then knowing what to do after. So essentially, we will give our chosen opioid. So for this sake, we'll say we chose the IV formulation. They had severe pain. We gave them we'll say a hydromorphone, 0.2 IV. And it's actually safe to come back in 10 to 20 minutes and say, what did we find? Because it takes about 10 to 20 minutes for these IV opioids to reach peak effect. What that means is what you came back to 20 minutes later is essentially what you're going to get. Did it work? Did it really help? Did it do absolutely nothing? By waiting any longer, you're not really going to see anything different other than maybe worsening pain. So if you come back in 10 to 20 minutes and you find that the pain is still severe and honestly your first dose did nothing, it is safe to give them another 100% of what you gave them. Now, if you came back and you actually brought them down a few points into the moderate pain pain spectrum, it's okay to give 50% of that cumulative dose. And if you came back and that patient started at a 10 out of 10 and you brought them all the way down to 5 or a 50% reduction in pain, you did it. This is already, we're in a better place, and this is a good place to work with. So again, whenever you're meeting this patient for the first time and you're trying to assess what they're going to need, your goal when you're dose finding is to bring them down 50% on the pain scale. So 10 to 5, 8 to 4, et cetera, et cetera. Now you can come back every 15 minutes, 10 to 20 minutes until you feel like you've reached that 50% reduction. Now, everything that you gave, even if you had to come back 4 or 5 times, everything that was given over a 4-hour period is added together. And I know this is what scares a lot of fellows and residents. They look at it, they say, oh, that's a big number that was added. But your patient showed you that they could safely tolerate and honestly needed multiple doses over that 4-hour period. Now, when you add those all together, that is your actual new opioid dose. And we'll talk a little bit about why that is. So this blue box is one of my favorite teaching resources to teach people because it shows you the difference between an opioid duration versus peak effect. Again, when we're talking about peak effect, we're talking about the onset of the best you're going to get out of this dose. So it takes about 10 to 20 minutes. Sometimes you'll see here, like, for example, hydromorphone 15 to 20 to really see what you're going to get. What that means is if I came back, say 40 minutes later after receiving an IV opioid dose, I know that that is the best that patient is going to get out of that dose. It is not likely to give them more relief if I waited even longer. And what that also means is I can actually safely give them another dose, knowing that it's going to not cause too many side effects and I'm not overdoing it. Now, for example, if I wanted to give morphine IV 2 milligrams, I would give it to them and come back 10 minutes later and see what they needed. Did it work? Did it bring you down from them 10 to 5? Did it bring you down from a 10 to 6? Did it bring you from 10 to 10? If, say, for example, I come back and it's 10 out of 10 still, I know that I can actually give another dose of morphine, even though it's only been about 10 to 20 minutes. This means that when you're writing orders, what is actually safe and honestly logistical, feasible, when you're writing IV pain opioid orders, you can actually safely write them Q1 hour PRN. Now, at our institution, the nurses kind of struggle a little bit with that on the general medicine floors, and we tend to write them for Q2 hour, but it is actually safe to write a Q1 hour PRN order for an IV opioid. And the reason is because when I come back after that 60 minutes, I know that's the best that patient is going to get. So unless they're really sedated or I'm worried about side effects, I know I can safely give them another dose. Now for PO, you'll see here that the time of peak effect is about 40 to 80 minutes. So if I come back 90 minutes later, I know that that is the best that dose is going to give them. So I can safely write it for Q2 hour PRN when they're in the hospital. Now, we'll be very reasonable here, insurance-wise and just logistically. When you are discharging someone with PO opioids, typically it will be Q4 hour PRN, just for safety and also insurance. For those that have constant pain, meaning I know that this patient is going to need around-the-clock pain relief, the pain is severe, they may be not able to tell you that they're feeling that pain because of aphasia or mental status, we can dose patients on schedule. And the way that you do that safely is to take into account the duration. If I know that the effect of the morphine is going to be 4 hours and I have a dose that really helped them, I can usually safely dose that PRN every 4 hours. That's scheduled every 4 to 6 hours. What that means is that I could do a morphine 7.5 milligram tab every 6 hours, and the patient's going to get it. And I already know that it's safe. And they don't have to keep asking for it. You don't have to wait for the pain to flare. Instead, it'll be brought to you. Now, in the event that I scheduled a dose for this constant pain, it means I also need something for breakthrough. And what you do is you take the total 24-hour amount that this patient is scheduled to get, and you multiply by 0.1 or take 10%. So that would be doing 10% of the 24-hour total dose would be the PRN for breakthrough. Now, there's a whole discussion about transitioning to a long-acting opioid. I would say that be careful. So you should never be starting a long-acting opioid for an opioid-naive patient. You should be starting with short-acting. seeing what dose they need and how frequently before you switch to long-acting. Common long-acting medications are MS-Contin, OxyContin. There is a long-acting Dilaudid that is available in Canada, briefly was available in our area and not so much anymore, but none of these should be what you're starting with. The long-acting opioids are typically every 12-hour dosing, and it really should only be used in patients who can tolerate it. Here we have the available opioid formulations currently known to us, especially in New York City. It has been particularly difficult to get access to some of these strengths, which is a whole other talk in itself. And I know something that we're actively talking about in the palliative care community. But when we're talking about discharge, I find that this chart can be really helpful in understanding what combination can I even be making for my patient? Elegantly, I love a long-acting OxyContin with a short-acting oxycodone for breakthrough. But honestly, the reality in a lot of our patients is that they will be on maybe MS-Contin for long-acting and an oxycodone immediate release just because that was available to the pharmacy. Side effects. So constipation, dry mouth, nausea, vomiting, pruritus, and sedation, those are the ones that you warn your patient of, that they are, no matter how long they've been on it, on these opioids, they will always have constipation. The nausea and vomiting tends to subside after about a week or two, but if it is an ongoing issue, it may be something that you talk about an opioid rotation. What is not tolerable? Meaning that, oh no, maybe we overdid it. We need to pull back in a really safe way. Worsening delirium or new delirium, myoclonus, urinary retention, and respiratory depression. Keeping in mind that those folks who have had too much opioid or maybe have intolerable side effects will fall asleep with sedation prior to the respiratory depression. This is something our residents always worry about. Oh no, did I suppress the respiratory drive? But the patient is alert and conversing with me. You are not there yet. The patient essentially will fall asleep and be difficult to arouse prior to any respiratory depression. Obviously, this is something that we are trying to avoid. This is the dangerous side effects of too many opioids. And that's one of the reasons why we're very conservative in our starting doses. Just a reminder, constipation will always be with you. It's essentially always a board practice question. And often, I think it was on my boards also, that the constipation will be with you as long as you are taking the opioids. Pruritus can oftentimes occur, nausea, vomiting, and sedation. The palliative care fast facts with the University of Wisconsin can actually be really helpful. They have separate fast facts on each one of these, opioid induced, and what to do about it. Everyone who gets an opioid for you should have a bowel regimen. Our preference is Miralax and Senna, mainly because we call it the mush and push. Miralax, the osmotic part, Senna, the push stimulant. The goal is to still have 1 to 2 days, a bowel movement every 1 to 2 days, and 1 to 2 days without pain or straining. Nausea is very common on initiation. Again, it tends to resolve after about 7 days, and Zofran or ondansetron can be really helpful for that. Sedation, particularly in older and sicker folks, can be really common, but that actually can get better over the following few days of taking it. And then pruritus, oftentimes the tolerance does not develop. You may actually, this is one of the more common reasons I have to switch off morphine, is people were telling me that they had too much pruritus. All right, so to put it all together, we have the case of Mr. Gomez, who's 62, hypertension, came to the ED with severe abdominal pain for the past 2 days. He noticed the pain for the past several weeks, described it as a gnawing or dull ache. But in the past 2 days, it's significantly worsened and it's very sharp. He can't sleep, and he's also had decreased appetite. He does mention that he's had some weight loss and fatigue over the past several weeks as well. In the emergency department, unfortunately, a CAT scan shows that he has a mass in his pancreas with concern for biliary obstruction. So we're looking at someone with worsening acute pain in the setting of a likely new malignancy. So you were called to manage his pain. All of these things, you did a great pain assessment and you saw that it was a 9, dull ache, worse with eating, comes and goes. It's affecting his quality of life. And he has a 9 out of 10 pain and grimaces during your encounter with pain that's reproducible with deep palpation of the right upper quadrant. That is acute, severe, nociceptive, probably visceral, since it's likely his pancreas and organs of being affected, pain. So the pain is severe, a 9 out of 10. That tells us an IV opioid is most appropriate for the how fast is the onset. Morphine is generally our first line, and his creatinine clearance confirms that it's okay for us to use it because his creatinine clearance is greater than 30 and he has normal liver function. So we take a look here and say, what do we need to start with? His pain has already surpassed the POI opioids and just doing acetaminophen and NSAIDs. We need to jump directly to IV opioids. You pick your starting dose because you know it's safe and he's never been on anything before, and you chose 2 milligrams IV. It's given. We wait our 15 minutes to hit peak effect. You come back, it's still a 9 out of 10. It didn't work. Oh no, okay. So that means we need to give him more. So we essentially gave him 2 milligrams at 9. We came back at 9:15. We reassessed the pain. It was 9 out of 10. And we gave him another 2. Now we've had a total of 4 milligrams within 4 hours. We came back, we waited another 15 minutes, and we brought his pain down to a 6 out of 10. But our goal is not 6. Remember, we want a 50% drop in our pain. So between 4 or 5 would be ideal. We gave him another 2 milligrams again, because that was a moderate amount of pain. We didn't want to give another 100%. We wanted to be conservative and safe. So we gave him 50% of his cumulative dose, which is 2. We came back another 15 minutes to wait for peak effect, and we found that he is at a 3 out of 10. He's comfortable, he's sleeping, and he's easily arousable and no side effects. You did it. You got him down from a 9 to a 3 without too many side effects and in a safe way. So now you add up everything he was given in a 4-hour period, and that was 6 milligrams IV. You now know that the 6 milligrams is what his body needs at one time to help his pain, and that you can give it to him safely. So your new order is 6 milligrams IV, Q1 hour PRN for severe pain. All right, you come back 24 hours later, come back for a reassessment. He's awake, he's talking, he's answering questions appropriately, and the pain medicine is working. He's going to have a procedure for a biliary stent tomorrow. Renal panel and hepatic function still look normal, but oh no, he hasn't had a bowel movement since before admission. Ugh, a jury nightmare for me. You look back at his MedRec history and see that he's gotten his dose of PRN morphine 6 times in the past 24 hours, and that is a total of 36 milligrams. Now I'm going to try and schedule his pain medication because he's still actively getting worked up. I don't expect the pain to be magically improved over the next 24 to 48 hours, and he showed that he can handle this dose safely. So we decided to take the total dose he was given over 24 hours and just space that out in a nice scheduled way. So in his case, we're going to dose by Q4 hours because he doesn't have any liver or renal dysfunction. And we know that the duration of this opioid is 4 hours. So we took 36 and spaced that out to 6 milligrams IV Q4. What you do is 36 divided by 6. Then we needed to come up with a breakthrough PRN, and keeping in mind that that would be 10% or times 0.1 of his 24-hour amount. In this case, we did 36 times 0.1, giving us 3.6 IV, and that is available to him every 1 hour PRN because that is what is safe. Now, we know that 3.6 for morphine is just not going to happen. So what we did in this case is round down because his pain was so well controlled, and we think that a 3 milligrams is going to be fine. Honestly, if you wanted to try a 4, I don't think it would be too much for him. But in this case, we were being very conservative. All right. You knew that he needed Miralax. It was on PRN. time to get it daily. I will make an argument, maybe it's the geriatrician in me, always make it standing and just have holding parameters, because it's really easy to forget that your patient's not having bowel movements. 1 dose of zoodancitron in the past, just for nausea, no change needed to that, and no somnolence. Now, 24 hours later, he's gotten, 42 milligrams of IV. He actually needed 2 PRNs in addition. You decided that you need to rotate him because now his creatinine clearance has dropped to 27 mils per minute, and that's under 30. So even though we felt like his pain was well controlled, we need to bring him over to Dilaudid or hydromorphone, because that it won't be as affected by his reduced creatinine clearance. Now you can see here, the morphine is on the left. Hydromorphone is going to be solved for X. And morphine 42 is what he got in the last 24 hours in the numerator. And the denominator will be what you find on your equal analgesic table with morphine IV. And in this case, the factor is 10. Now, when I'm solving for X on the right side, in the denominator will be 1.5 milligrams IV hydromorphone, because that is the conversion factor from our chart. And the numerator will have X. Multiply 42 times 1.5, divide by 10, solving for X, back to algebra. And you found that 6.3 milligrams of hydromorphone IV in 24 hours is what the equivalent would be. Now, what we do have to think about is solving for cross-tolerant or incomplete cross-tolerance. And in this case, we brought him to 1 milligrams Q4 hour scheduled with a 0.6 milligrams IV Q1 hour PRN. But don't forget that you would probably consider bringing that down to maybe 25% of what you were giving in the morphine, to make sure that you're not going to hit those receptors too hard with the new medication. Now, I know we're running out of time, but he's approaching discharge. His creatinine clearance is back. He had been doing really well on the standing hydromorphine that you were giving him. And now he has to find a new outpatient regimen. We know that the source of his pain is the pancreatic mass, and that's not going anywhere anytime soon. So we don't suspect that his pain is going to magically improve. You decide to switch him back to morphine IV. Again, hopefully you can work your way through this, but you can always look back. The morphine 6 milligrams IV Q4 hour scheduled, and the morphine 3 milligrams IV Q1 hour PRN, that was what he was getting before. And he used 42 milligrams IV. That was what we combined 2 slides ago. And now we will use that same equal analgesic table to convert IV to PO morphine. So you'll see on the left, the numerator and denominator are both IV. The numerator is what he's used. The denominator on the left is the conversion factor. You're going to solve for X on the right in the numerator, and with the PO morphine in the denominator, you look into the chart here and see that morphine PO is a 30 milligram conversion. And now you find that the total morphine PO equivalent from 42 milligrams IV is 126 milligrams. And based on what's available to us, we are able to put 60 milligrams MS-Contin Q12 for a total of 120 milligrams per day, almost to his 126 that he was requiring here. And we will then give him the morphine 15 milligrams PO, Q4 hour PRN for any breakthrough pain, based on what we do, 126 times 0.1, 10% of his 24 hour. All right, you did a great job. Please don't forget about the Miralax and Senna. And he's discharged home. He sees the palliative care in 2 weeks, and he says that his pain has been well controlled, and he's only used his PRN 1 to 2 times per day. You did it. I hope this was helpful. Please feel free to pause and work the math yourself. I find that the more times you do it, the easier it becomes. I know that it can be hard to mix up the proportions, what goes on the numerator, what goes on the denominator. The best advice that I was given and that I take with me is just make sure those numerator and denominator units are the same, and that will help you not mess it up. I hope you have an amazing CME conference, and it was really a pleasure to be a part of it. Thank you.